Thank you for giving me the opportunity to talk about lung cancer. Today, I will talk about the lung cancer in detail a little bit. I am, as Ravish already told, I am Dr. Sanchayan Mandal. I'm a consultant medical oncologist. I'm practicing in Kolkata. Lung cancer is a huge burden globally, not only in India. In USA or westernized country, actually, the lung cancer falls into the first five cancer, be it most common incidence or mortality or death rate of the patient. In India, in male person or the males among males, it is constitutes of the second position after the head and neck cancer. And in all over, if we consider both male and female, consider in India, it comes after the breast and cervical cancer in third position in India. So lung cancer, as we know, that lung cancer basically, as we know that we have the tumor mass that actually proliferate very aggressively and uncontrolled manner. Just that's the nature of the all lung cancer, and it grows inside the lungs and spread to the in and out surrounding organs and also to the distant organ. So first, what is the symptoms? Symptoms as like cough and hemoptysis. This is the most common symptoms. Patient may get weight loss a little bit later in advanced stage. And in advanced stage, patient also had the other symptoms, because in advanced stage, what happens, the lung tumor or lung cancer spread to the other parts of the body, like patient have a bone pain if the patient has a mass in the bone, or has a seizure or convulsion or headache or double vision if the tumor goes into the brain, or have a brain metastasis. If the patient has a liver metastasis, may patient complain of the pain abdomen or accumulation of the fluid in later stage, like that. So lung cancer is a very deadly disease, and it should be recognized in the early stage. And as you know that we have the very high preponderance of tobacco smoking. This is the most common risk factors of the lung cancer. And apart from this tobacco smoking, any form of tobacco that can cause lung cancer. And it has been seen that apart from the tobacco smoking, the pollution, and in case of female, those who are most chunk of the bulk of the patient, who female most common, we have categorized into the Asian female non-smoker. They actually fall into the specific subtype that is called the adenocarcinoma of the lung. So adenocarcinoma of the lung in female, it is around 50%, and in male it is around 1/3. So adenocarcinoma, it is mainly common in the non-smokers, and in smokers, squamous cell carcinoma of lung or small cell carcinoma of lungs are most common. These are the actual histological types of lung cancer. Now, these are the risk factors, and we have also seen those female patients who actually use the chulla, to use the bow pipe to actually you inflame the all the other inflamed or the gas. The gas is not available in the village purpose or the urban, not urban, like the village or rural area, where they used to use that chulla. So in that type or kind of chula, they actually get the air pollutant inhaling for the long time, and that cause the lung cancer. Another risk factors of lung cancer are asbestosis. Those actually, these are the occupational hazards, we call it. And in these cases where there is a chance of lung cancer, where they actually that asbestos particle that may basically in asbestos in the industry or mining industry, or radon. In USA there is a radon plant is there, where there is a much preponderance of the lung cancer. So we can tell that for the regarding the risk factors, these occupational hazards, and those people who work in this radon in a plant or the mining factory or the asbestos factories, they should be regularly check or screen for the lung cancer. So these are actually the risk factors for the lung cancer. Now, I have already told about the symptoms, that whatever the organs they actually involved, and this type of symptoms they may manifest. And in case of the diagnosis part, what happens, what I feel in my day-to-day practice, we have seen lots of lung cancer patients, that the lung cancer is actually the patients came in very late stage of the disease. Okay, in USA, as there is a insurance coverage and patient are more aware, and there is a lung cancer or general cancer awareness is very high among the and the people. So the type of the cancer, this lung cancer, detected there in westernized countries in very early stage, where they have the option for surgery. Whereas in my practice, I have seen that the lung cancer, as there is a not such any awareness is there, and much they are actually negligent by quitting the smoking, and don't go regular screening in the high risk occupational hazards, and their day-to-day life regarding the pollutions and chemical from the plants, etc., that I have already discussed. These can cause the lung cancer, and they present in the advanced stage in our country, in India. So basically, as I have told, that lung cancer can be limited to the single lung parenchyma, that is the localized disease. When this lung cancer spread to the nearby lymph nodes, this is called locally advanced disease. And when the lung cancer spread to the other part of the body, that is called the metastatic or stage 4 lung cancer. So in localized disease, when there is a no other lymph nodes or no other organ involvement, patient is health and heart patient is fit, and we assess the patient as the ECOG performance status, and there's a performance status is good, then we have to plan the patient for surgery. And we have the, and as a consultant medical oncologist, after the surgery, we have the role for maintenance targeted therapy, that is called the osimertinib maintenance or immunotherapy maintenance. So we have the option for targeted therapy maintenance, that is that shows a very good progression-free survival, and eventually increase the overall survival in some patients. And we have also have the neoadjuvant setting before the surgery. We have the immunotherapy and chemotherapy combination, nivolumab and chemotherapy combination. And it has been seen that in surgery before the as a neoadjuvant treatment, did actually increase the pathological complete response or good response after the surgery, and patient may become the disease free for a quite long time. And in case of the where there is a much lymph nodes are positives, and patient tumor size is big that cannot be controlled on the surgery, then we switch to the next mode of the therapy, that is called combination of the chemotherapy and radiation therapy. And it is followed by the maintenance immunotherapy for 1 year. And I have personally used this kind of immunotherapy called durvalumab. And I have seen these patients a very long, good progression-free survival, and eventually overall survival. And in metastatic setting, stage 4 lung cancer, when the lung cancer is not localized to any specific places, that is already metastatized to other places, in that cases, we have seen that new modern medications or the upliftment of the science has led this medical oncology to revolutionize in this management of the stage 4 cancer. And that I can tell, that's just if we go back 10 years back, then there is the only option for chemotherapy. And when the stage 4 lung cancer patients comes to our OPD, we just designate them that this life is very short, is only month of 6 months to 1 year survival. Whereas the data shows after the evolution of this targeted therapy and immunotherapy, as a medical oncologist, I have seen this 11-month or 1 year survival has increased. 5 year survival in case of stage 4 lung cancer is around 17% to 20%. So with the upliftment of the science and upliftment of the modern medications, targeted therapy and immunotherapy, we actually prolong the survival of the patient in stage 4 lung cancer. Now, I can give some examples of my own experience that some of my patients, suppose we actually give them the targeted therapy, and we when the patients comes into our clinic, we actually undergo the biopsy from the lung lesions or the easily accessible site. And if the biopsy is not possible, we can also get the help of the liquid biopsy, where we can get the diagnosis, and also we can do the specific marker for the targeted therapy like EGFR, ALK, ROS, MET exon skipping mutation, like that, and also for immunotherapy PDL1 test. So these are the basic tests that we do in case of our lung cancer patients. And when our patients come, this is the series of the tests we will do. And after that, we decide according to the report. We actually decide that what type of therapy will be beneficial for the patient. If the patient has the EGFR mutation, then we can go for first generation, second generation, third generation EGFR inhibitor like afatinib, docomatinib, and third generation osimertinib. And all these medications have led to a splendid result in these lung cancer patients. Whereas if the patient has the ALK positive mutation, we have the lorlatinib, very good. I have personally used it. And in case of MET exons 14 skipping mutation, I have used tepotinib. And this is a new launch molecule. Last year, it has been launched in September, India, and I'm fortunate enough to apply in one of my patient. I get a marvelous response, and in very soon I will publish the paper for that. And in immunotherapy also, I got a very good response. Like if the patient is a PDL1 positive, and according to the positivity of the PDL1 marker, we actually see the response of the immunotherapy. So if the percentage are high, then immunotherapy response will be much better. And we have seen if the PDL1 is more than 50%, we can go for single agent immunotherapy atezolizumab. If the PDL1 is less than 50%, we can go for a combination of the chemotherapy and immunotherapy like pembrolizumab or atezolizumab along with chemotherapy. So these are actually summary of the recent modern treatment of our medical oncology field. And I personally have feel and seen that this type of immunotherapy and targeted therapy actually revolutionize the survival of the patient in case of stage 4 cancer. And these actually very good benefit for the patients as and very satisfying for a treating doctor also. And one more thing that we would like to add, that for this use of this targeted therapy, immunotherapy, it is better to have our health insurance, because health insurance cover all these things very good. So and patient may get the very good treatment till the long term. And this is actually, it is continued till the progression of the further progression of the disease, or further toxicity development, or the patient financial toxicity unable to continue the further treatment. So these are actually the gist of the treatment. In stage 4 cancer, surgery role is very limited, and we have the palliative radiation option. If the patient suppose have a bone pain, or the patient has a brain metastasis, have a symptoms, then definitely we do the palliative radiation in form of whole brain radiation, or the palliative radiotherapy to bone for the symptomatic improvement of the patient and to maintain the quality of life. And in my clinical practice, I always prefer, my motto is to maintain the quality of the life of the patient, number one. Number two, to preserve him in the well health, and to give him a longevity for his survival. So that is the motto of my treatment. In USA, there is a screening program. Those who have the 15 years history of smoking, they have a low dose CT scan every yearly for at least 3 to 5 years. Then they actually keep on follow up. But in this type of screening program is not followed in our India. And I actually personally, in my every cancer campaign, I actually personally advise all people regarding the strong hammer the point that against the smoking, that you should stop the smoking, avoid the tobacco, etc. Avoid the occupational hazards, to get screened every frequently to get the occupational hazards, those who as associated with, like I said, asbestos industry or mining industry, like that. And always use the face cover or face mask who are in, like in traffic guard, who are actually in between the roads throughout the day and night. And they actually have a actually pollution, be it environmental pollution, be it a vehicle pollution, they actually exposed to that. So use of the mask, and we all habituated with the use of the mask in after the COVID era. So I think this N95 mask uses, avoid the good sanitization, proper hygiene, good well ventilated room while doing the cooking, get the screening regularly in case of occupational hazards, and stop smoking, avoid tobacco in any form. I think that will cut the incidence of the lung cancer, because the cancer proportion or incidence or of the cancer actually booming. And it has been seen that in 2000 by 2025, the burden of the global burden of cancer burden of the India will cross 30 million. And it will happen that in next 10 years, every family have at least one or two people affected with cancer. So cancer epidemic is about to come. To curb this cancer epidemic, we need to do it from now. And that is my piece of advice. And over to you, Sreyoshi, if you have any question to ask.
Thank you so much, sir, for the comprehensive talk. The presentation was so much informative. And yes, we have received few questions from our participating doctors. So with all your permission, I'm putting them
Yeah,
across.
please.
Okay, so the first question we have received from Dr. Rajiv Mishra, and he is asking, what are the consideration for patients who have progressed on initial lines of treatment or who experience disease recurrence?
Sorry, say it again.
Yeah, sure. And the question is, what are the consideration for patients who have progressed on initial lines of treatment or who experience disease recurrence?
Yeah. What is the name of the doctor?
The doctor name is Dr. Rajiv Mishra.
Hi, Dr. Rajiv. Thank you for your question. Basically, see, if the patient has a initial treatment, suppose a patient has underwent surgery or radiotherapy, or as I told that I have the experience of durvalumab maintenance for 1 year, immunotherapy. And after that, you have to keep in follow-up of the patient, regular interval. We'll do the regular imaging, blood test, have the clinical examination to know the early recurrence, or if the patient has any suspicious clinical symptoms that on follow-up I find, I definitely don't overlook it and go for the investigation further, like imaging. Suppose a patient on follow-up came with a convulsion, or the patient has a double vision. Definitely, I will do the MRI of brain and see is there any metastasis present or not. If the patient has a bone pain on the follow-up, he was absolutely fine, and now patient complaining of severe bone pain. Definitely, I will go for my choice of investigation will be PET CT scan. So in this manner, we actually find the recurrence of the disease or the new appearance of the disease. After that, we do the rebiopsy of the lesion that we find. Where is the actual lesion? Then PET CT scan is a very beautiful imaging. It shows actually the where the tumor is recurred. Only the localized area or any other parts of the body are involved. And as I've already discussed in my session, that will go for the biopsy. If the biopsy is not possible, a liquid biopsy will do, and we'll definitely see the type of the histology. Like suppose patient has adenocarcinoma, patient now their histology has been changed to small cell carcinoma, squamous cell carcinoma. So that we have to find, and definitely you have to go for the targeted mutation studies and immunotherapy marker studies, and after that you will decide for the next line of therapy. Yes, Sreyoshi.
All right, sir. So we are moving to the next question we have received from Dr. Radhika, and she's asking, how does the era of modern therapy for lung cancer impact the overall prognosis and survival rates for patients?
Yeah. Hello, Dr. Radhika. Nice to have your question. Basically, as I have already elucidated that as I'm a medical oncologist and I'm using this targeted therapy and immunotherapy for a long time, and I have seen that as I have showed the data that just 10 years before, we stamp the patient that you have the survival for only 6 months to 1 year, and this survival has increased tremendously by use of this targeted therapy and immunotherapy if the patient respond good, because I have seen that 65 to 75% respond very well, but unfortunately 25 to 35% patients don't respond. So in that cases, we don't have any options much left apart from this chemotherapy and other supportive care. But those who actually respond well, we can actually increase the survival. So definitely we will go for the targeted therapy and immunotherapy before that chemotherapy has the hand in the third line setting. Yes, Yoshi.
Thank you, sir. Moving to the next question received from Dr. S. Roy, and he is asking, are there any ongoing clinical trials or research studies aimed at further improving the efficacy and outcomes of modern therapies for lung cancer?
Name of the doctor?
The doctor's name is Dr. S. Roy.
Hi, hello, Dr. Roy. Nice to have your question. Basically, yes, there are many ongoing trials. Previously, I was in Delhi in Gurgaon Artemis Hospital. So we have the many international clinical trial was going on. And definitely in Kolkata also, we have many hospitals. We have the many national and international clinical trial that has been going on. And like in Mariposa 2, we have actually as a fortunate enough to have a co-author in the clinical trial, and we have seen in exon 20 mutation CA lung, we have used the amivantamab and lacertinib along with chemotherapy. Yeah, there is a 3-arm study, and we have seen a very marvelous response to that. Okay, so yes, definitely there are many different trials are ongoing, and this the as the science is ongoing, there is a different new targeted lesions are coming, and actually we are working on it to develop the new molecules also to get the best hard hit of the tumor by this targeted therapy and get the best response. Yes.
Thank you, sir. So let's come to the second last question from Dr. Shivam Rathore. And his question is, what are the challenges and consideration in managing the side effects and toxicities, and how can they be effectively managed?
Dr. Rathore, yeah. Nice to have your question, Dr. Rathore. Basically, see, side effects profile are different for different types of therapy. Like I told, 3 types of modality. One is targeted therapy, one is immunotherapy, one is chemotherapy. Chemotherapy side effects, as we know, it is very traditional: nausea, vomiting, diarrhea, low count or myelosuppression that leads to fever, and very rare cases, 2 to 5% cases, some anaphylactic reaction or cardiac problem. In immunotherapy, as the mechanism of action is different from the chemotherapy, it actually augments the immune system of the body to kill the cancer cells by augmenting the T cells. Okay, so basically immunotherapy, as it augments the immune system, that can affect all body parts. But what we have seen in immunotherapy, we have seen that thyroiditis or endocrinopathies, pneumonitis, hepatitis, skin rash, or dermatitis, this type of autoimmune mediated side effects are more common. and we have managed it well. And that's why trained specialist in immunotherapy and target therapy, that's needed, because in when we are administering the immunotherapy or target therapy, we be cautious about the patient to detect the early sign and symptoms of the side effects, so that we can detect it in a grade 1 and grade 2, because as we know CAT side effect criteria, and it has graded into grade 1, grade 3, grade 4, and grade 5. So we have to diagnose and find it very early stage, so that we can quickly manage them. In targeted therapy, depends on the type of the tablets or the oral tablets I am using. The side effects profiles are different. So before starting the immunotherapy and targeted therapy, even chemotherapy, I personally counsel my all patients in OPD what may be the side effects. Maybe a 2 to 3% anaphylaxis or dreaded complication, or maybe a natural general complication. That I think as a clinician we should counsel the patient before starting it.
All right, sir. So the last question of today's session is, we have received from Dr. Nisha Saxena, and she's asking, how can healthcare professionals stay updated on the rapidly evolving landscape of lung cancer therapies and breast practices?
Dr. Saxena, yeah. Nice to have your question. Basically, in my cancer campaigning program, what I hammer when I actually talk in front of my cross specialties like medicine specialties, pulmonologists, gastroenterologists, surgeons, general practitioners, family medicine practitioners, gynecologists, all subjects, all our allied branches, because you know that medical oncology is a referral branch. And when the patient hit at your clinic at first before hitting my clinic, right? So what are the earliest signs and symptoms of the cancer, that so that you can pick up and at your very early stage when the patient's first walking into your OPD, and immediately you can refer us at the very early stage. That is very crucial, and this time frame is very crucial for the survival of the patient, and also early diagnosis and early treatment. As I told, that lung cancer, if we are detected in a very early stage, that we can go for resection or surgery. Whereas if I go on the locally advanced, the surgery option is omitted. Then his option is chemoradiation followed by immunotherapy, or patient landed into the stage 4 cancer that I have already told the treatment in details. So lung cancer, I have seen what I have seen in my clinical practice. First, suppose they go to the some in village or rural area, they first goes to some quacks. After that, one their diagnosis, they some refer to the urban area, there's some general practitioners. And what happens, suppose a patient has a cough and cold or cough and hemoptysis, everybody should look for the any mass apart from the excluding the tuberculosis. So what happens, suppose patients have receiving, I have seen the patient received multiple course of oral antibiotics as the patient has a cough and cold, and nobody some advise the patient for chest x-ray or the HRCT chest. And some physicians offered them suppose anti-tubercular drug for a long time. And when the patient landed after the 6 months, the patient is in metastatic stage. So this is actually current scenario that I'm dealing with while seeing the patient in my clinics. So I think the early signs and symptoms, and as I already have my own YouTube channel, and in my own YouTube channel, I actually give the different short videos. What are the important hitting symptoms and signs of cancer? Yeah, you can go through my videos also. You can learn it, although it is in Bengali. And in general, lung cancer patient present with this cough and as a hemoptysis, weight loss, or if the patient meets has the associated symptoms, which organ they have affected. If the patient has a strong history of smoking or tobacco, definitely you should suspect lung cancer. So, to prevent or curb the incidence of the lung cancer, I think when the patient present to your clinic with cough and hemoptysis, don't ignore or don't see it as only the infection. You should go through a rapid series of tests to exclude the whether there is a small space occupying lesion is there, whether there is a lymph node swelling is there, or any other symptoms that is going on your doubt. And I am very open to all of you. If you have any doubt, any clinical scenario, if you have any help, any opinion, I am open to all. You can just search my WhatsApp number or email me, and I can definitely guide you and help you for proper diagnosis as very early stage of the patient.
Thank you so much, sir, for answering all the queries of the doctors. And I would also like to thank all the participants, doctor, for your continuous participation at our platform. And thank you once again, sir, for your valuable time and sharing such valuable insights and being with us on our platform. So, sir, with all your last comments, we can conclude the session over here.
Yeah, thank you, Sreyashi. Nice to
Thank you
meet you.
so much, sir.